You're live. Okay, good morning. This is Senate Health Welfare. It is March 12th, and it's a day before crossover, which is really good news because the sooner we get through all these bills in front of us, the happier we'll be. So, and I know everybody wants us to do everything all at once, but that's sometimes not possible. In fact, I don't think it's ever possible. We'll do what it can do. In order. So we don't have Ledge Council with us until 9:30, but I thought it would be helpful to look at S-194. It is a bill that we started talking about during the BAA process. And makes sense to look at it. We do have written comments coming in from the agency, so we'll look at those, and we may not get anything accomplished on the bill until tomorrow. And if we can't do it by tomorrow, we'll also have an opportunity to put some language into the big bill or into another bill at least, but we do want to pay attention to this payment methodology issue. So S-194, I think we went through briefly previously. I'm going to phone a friend. Kelsey, you're here, and I would for you to provide your testimony on the bill. It may be that it comes in before some folks are fully aware of all the details in the bill. So just you know that. So be as offer as much clarity as possible if you're going along. And do we have your testimony in writing?
No, I have a PowerPoint that I'll use to help
Perfect.
guide the conversation, and then Amy Johnson has some written recommendations for follow-up that we'll use. But I wanted to give my intention is to speak to the bill, but give kind of the reasons and overview, and then answer questions if that'll be helpful.
And just so you know, we're going to try to finish up this bill by 20 after 9 and give ourselves 10 or 15 minutes on S-154, the biomarker bill. That it's the end of the sessions, end of the crossover, so it got taken off the agenda accidentally, but we'll put it back on. That's happened to several bills. Everybody gets all upset. Here we are. Okay, so go ahead, Chelsea.
Great. For the record, my name is Kelsey Stavseth. I'm the Executive Director at Northeast Kingdom Human Services, which is the designated agency that covers the 3 counties in the Northeast Kingdom. And I'm also co-president of the Vermont Care Partners Board. So I will, and I'm here to speak on S-194 about payment rates for providers of community-based services. Let me share my screen here. Okay, that should be full screen. So I'm sure you all know this, but Vermont Care Partners represents 16 agencies, so designated and specialized support agencies across the state. And so we represent every county and provide mental health, substance use, emergency services, developmental services, as directed by Dale and DMH. For the framing of this, I think it's really important about how we think about the DA and SSA system. And so really saying we provide expertise, and I really do feel like we're the experts in community-based mental health, substance use, and developmental disabilities. We often get referrals from primary care, hospitals, first responders, including law enforcement, and saying, we can be the last stop before inpatient or higher levels of care, like residentials for children or out of community placements for therapeutic schools. And so we're trying to do everything to keep the Vermonters we support in their communities. And I think we do a pretty good job. So what S-194 we feel like is really getting at is like saying, look, what issue are we trying to solve? And really it's saying, what services do Vermonters need to be successful in their communities? And we know that some of the supports folks need to, one, keep themselves safe, keep our community safe, to support them to be valued and contributing members of their communities, requires expertise, therapeutic support, case management, and other supports that help people um, live the life that they want and also contribute to their communities. And just as an example for us, one of those is transportation, as we know, I talk about, and so being the ruralist area in a rural state. Um, Last year, we drove over 1 million miles to get people to their jobs, to get people to their healthcare appointments. And so it's critical that those costs are taken into account when we're providing services. And so um, the bill, I think, is addressing um, what is the total cost of providing services to get the outcomes we want. And I want to frame this saying there are lots of things happening. So, Act 167, we know that health insurance costs are high, some of the highest in the nation, that is putting downward pressure. We feel that specifically as an organization that provides robust benefits, healthcare benefits, that goes up every single year and puts pressures on our costs, but also our ability to pay higher rates to attract people to do the services. It also means that when we can't recruit or provide the services that we are required from DMH or Dale, that the unintended consequences is often that people go to other services that can be crisis and not fall through, like hospital or emergency rooms, which can be more expensive than if we right size our payment rates. And so we are working on CCBHC, where we recently went through DS payment reform. And so there's a lot to be worked out, but what we're finding is that we are struggling to cover cost for things like residential care in DS and in other areas. And so we have not had a formal sit down to saying, like, what are the true costs of the services to get the outcomes that we want? And so this bill helps to establish that formally, and would guide AHS in setting rates that allow us to fulfill our mission. Um, Okay, so here's a couple things that are going along. I think you're all well aware of this, but CCBHC, there are some designated agencies headed towards CCBHC designation. 2 are currently in there. 4 more are going in the summer. We've also been transitioning to DS payment reform and conflict of interest and saying, we did work closely with Dale and appreciate that they continue to work on this. We're about 6 months in and finding that the transition has impacted revenue for a number of organizations. It has the potential to destabilize some pretty significantly who are working with the department to figure out how to stabilize their organization. And in this, it's also not adequately covering the residential costs for folks who need medical care, who need staff living, who need long-term care. And as you know, we have an aging population, and when combined with complex care like medical needs or mental health needs, it can become expensive. One thing I want to highlight about DS is that I feel the network does a really good job of supporting people in staff living to a nursing level of care. And so one thing I actually think that this could benefit from is saying we do a good job. We have nurses that designate lay people to do specialized care procedures, and we support folks with developmental disabilities that also have complex medical needs. And we do that in the community with staff that are not technically trained but overseen by a nurse. And I actually feel like that is a savings to the system. But if it's not paid enough to keep those people coming in or keep our nurses on staff, then you start to get folks who are going to need inpatient levels of care or are going to be languishing in hospitals or nursing homes that don't feel equipped to do this. So without investing, I think we can bring investment up without it costing more than other higher levels of care, but can balance the need of capacity in our community. And so this process would help align costs with higher level system goals. And so this isn't built into the study, this isn't built into the bill saying like this must happen. But one of the things that we would be in support of to figure this out is a study. And so I think it's important that we have a robust study. We've done that with the hospitals. I think it's important to consider the designated and specialized service agencies and the community-based services into healthcare reform. If we can keep people in our communities, if we can keep them out of higher levels of care, we can not only provide better services where people want them, but we can also save money um, in a healthcare system that is costing more and more every year. And so what we would be open to and would like to consider is a more formal study of the system to saying what services should be core and provided and available to all Vermonters. We have started that process a couple years ago, but um, there's a lot going on, and so we want to make sure that that could potentially be formalized and completed. And saying how do the DAs and SSAs fit into things like Act 167 and healthcare reform? Uh, Oftentimes, what happens when we don't have a formal strategy about how these things all fit together, we can get piecemeal situations where, maybe that looks good for the program, but when you take it as a whole with added informal expectations, the costs outmatch the resources, and then you get a watered down system that's not fulfilling its obligations in meaningful ways to Vermonters, which not only impacts the people receiving services, but then has system impacts that weaken the entire system. So reasonable and adequate. Again, to start, why we said we're the experts is that we often get referred the most challenging. And so for adults, we talk about SMI, serious mental illness, in children, severe emotional disturbance. That's the language that's used by SAMHSA. But what we can find that happens is saying we not only bring people in, we license them, we supervise them with our clinical license folks for free, which we're adding capacity to the system. But once they get licensed, they can make more money in private practice, in primary care, in the hospitals. And then what happens is we lose our most talented folks. They go somewhere else, and then they refer the most challenging cases back to us. And so we're put at a disadvantage to fulfill our mission of the most complex situations without being able to pay rates that are competitive for the expertise that we provide, which creates an inversion in the system, which I think actually puts more pressure on the system at large, and which costs more money. So prospective payment methodology stabilization. So like, how are these rates structured? It has been challenging to saying, well, we think this is best guess. We're going to try it. Have worked with the departments to make sure this works, but oftentimes we're not sure how it works until we're well into it. I think DS payment reform is a good example of that, saying in the residential piece, it is looking like over the 6 months that the rates that were paid are not covering costs. And so what that requires us to do is subsidize important services that we have to provide with other programs. And so that creates an unnatural strain on the system. Mindful of time here. Okay, so I'm going to stop there just so we have a few questions, or if there are a few questions. I know we're trying to end at 9:20, but in general, we're supportive of the bill. I think Amy Johnson, our Director of Policy and Legislative Advocacy, has some suggestions that can be passed along, but wanted to talk about or just give a high-level overview of where we stand as a network.
Thank you. I do have two questions for you. So in addition to your contracts with Dale and DMH, do you have other contracts outside of your state responsibilities?
We work with the Department of Substance Use under VDH currently. And so we do provide substance use services, but I would say that a majority of our work is through the state. We do have other grants, those often enhance the work that we're doing with the state. And so I would say that almost all of our services are focused on DMH and Dale requests.
Okay, thank you. And then conflict-free, if you could talk a little bit about the separation of the case management and the actual delivery of services. So the federal rule that has put us in this place, just really 20 seconds.
Okay, I'll try my best. So, the state of Vermont needed to come into compliance with the federal government through CMS and what they're calling conflict of interest free case management. And so essentially what that's doing is separating the organizations that provide direct services from the people who determine people's treatment goals. We call those ISA and DS, and the funding. And so what the government is saying, there's an inherent conflict if you're assessing folks and determining what their treatment should be and what they should get paid, and then providing that. And so that uncouples funding from service delivery, which in theory is good. I think what Vermont had developed is a vertical integration that allowed for thoughtful and quick flow through the system to provide services quickly to folks. And so that has been decoupled. We brought in two external to the state case management organizations, another organization external that is doing the assessments. And so right now that's putting some pressure on all of those organizations to learn a system, and is creating bottlenecks and challenges, which we are supporting with, but have essentially carried on the same duties that we had before to make sure that people are getting the services they need.
Okay. Thank you. That's helpful. All right, so we'll keep going, because I know, I'll tell you that I know that Ledge Council will be happy if we go over this a little bit. We should work hard. Amy, why don't do you have specific testimony that you're going to offer?
Amy Johnson, Vermont Care Partners. I don't have specific testimony, but I do have language suggestions for the study.
Good.
And supporting a work group for the habilitative and rehabilitative.
Why don't you come up and offer that? And then I know that they, that Dale was interested in commenting. Do we have it?
No, I haven't sent it yet.
Okay, well, maybe do that.
I will.
Yeah.
Sorry, I have sent it a few days ago, but it wasn't formalized. I do have a formalized version that I will send to the committee.
Plan through that.
We're looking to have a study that will look at our entire DA SSA system of care. So Kelsey spoke to it kind of briefly, but we want to review the services currently provided by the DAs and SSAs, including identifying what is essential, what are our specialty services that are being delivered on behalf of the state, review statutory, contractual, and administrative frameworks guiding the DAs. I did over there, but I can do it again here. Then Amy Johnson, Vermont Care Partners. An analysis of emerging needs, pilot initiatives, and system transformations, and how they've expanded or altered agency responsibilities over time. Consideration of the system's sustainability, including workforce capacity and strengthening, addressing administrative burden and strengthening the long-term stability of the system. So we're interested in, I created a group that we can add members to, but we do have a designee from the Agency of Human Services, Department of Mental Health, Dale, as well as the Developmental Disabilities Council, individuals receiving services, a family member of individuals receiving services, and of course, our folks. So we didn't, and we try to keep this pretty basic and simple because we want to be able to work in collaboration with the administration to guide this process. We don't have funding attached to it or specific dates. But I think what we're seeing is there are gaps in the system. There's things that we're required to do, and often there are things that are added onto our plate, not necessarily with increased funding or contractual agreements. So we're really looking to see what is our capacity, what are the essential duties, what are the gaps, and really looking at where the system is now and where we should head, and how that fits into healthcare reform. So that's the study. So
And I
the
think
other,
it's helpful. Oh,
yeah, Kelsey,
sorry, I
jump
just
in,
to
please.
speak to that is saying, one of the challenging things that we've navigated is also saying we are in state statute. I think it's fair to say that the designated and specialized service agencies are the action arm of the departments. And so these are required services for Vermonters, and saying every single year we've had great allies in the legislature, which we so appreciate here and in the House, but we have to come back every year to ask you for rate increases to cover things like cost of living. And so that is automatically passed through in the state, which we also support, knowing that things cost more every single year, and that's been exacerbated in the last few years. But if that's not guaranteed or at least meeting inflation, then you're talking about service cuts every year. And what we have seen is that the need has been increasing, and that doing services upstream, preventative, especially in early intervention with children, is going to have the long-term impacts that we want, not only for keeping people and children in their communities, but alleviating pressures on higher levels of care, which is where people go when services are not available. And so I do think that the bill as put forward and the study helps address saying, like, what are the outcomes we want and what would the cost be in the context of healthcare in Vermont. So I think we're trying to emphasize the fact that we're here to fulfill a required or required work of the state that is important to Vermonters. And we can
No,
do
that's
that in a
good.
thoughtful way.
Understood. And so the analysis of where we are today, I'm really pleased to hear that you're including the state planning process, because that is a big part of transformation that's ongoing. It probably shouldn't be separate.
Yeah, it's
So thanks for that. And you will send it to Callista if you haven't already, because we need to see it.
Yep.
I'm also posting a letter from the administration that talks about the bill as it currently stands, or the provisions of the bill, and one would put us in jeopardy in terms of Medicaid.
right.
And so there's some changes that we'll have to look at. If the study goes in, it might be that that's what goes in. And it makes more sense to do the study before we decide to change everything. So
Right.
and I know Senator Morley's gonna ask a question. Okay.
So I'm looking at the bill as introduced. That's what I'm looking at. And so you'd be adding the study somehow into, we'd amend it, just. put
Yeah,
everything.
we'll amend it.
So this reminds me a lot of the primary care bill, Madam Chair, because it's per member per month.
Yep.
And so is the study going to be also looking at how it's going to be paid for? So I mean, you're going to be looking at Medicaid, you're going to be looking at private insurance companies, you're going to be looking at a whole, I hope your study's going to do that. Not just outcomes as far as, there's two sides of this, right? You've got your side providing the services.
Right.
Then you guys look at how we're going to.
What's needed.
Right.
Right,
exactly.
Yeah, what's needed.
But then you can also figure
Yeah,
out.
so that you pay for it.
Yeah.
Exactly.
Well, I don't know if your study's gonna include
Yeah,
anything.
ideally it would do a robust analysis of what's happening and the funding that's needed to cover the cost of those essential services to Vermonters. And we do have payment methodologies. We talked about CCB, CTSP reform. So these are big reform processes that are actively happening on the adult and children's mental health side. That happened a handful of years ago. So we have had these reform efforts, but how do they all fit together? How are they all impacting each other? Where are the shortfalls? Because we know that for some of these efforts, the cost is not, what we're getting is not matching what the cost of care actually is. And obviously we don't receive the inflationary increases that are needed. CCBC does have that baked into that model, but not all the models have that baked in. So often we come to the legislature for those inflationary increases.
So this would help alleviate some of that.
Ideally,
Reading from what you would like.
yes.
Okay, other questions? Go ahead.
As I understood it, you had some specific language for setting up this study that you're going to submit.
Yes, I will send.
Thank you.
And the memo that comes from AHS, Agency of Human Services, does address the bill and also the willingness to work on a study of some type. So we have today and tomorrow. We'll see what we get. If there's language forthcoming from both sides, we can evaluate it and put something together ourselves. And then try to move it along in a way that the House will be able to pick it up and improve it.
I do have one additional piece that you'll see in what I'm sending to Callista, and I know that we're
Yeah,
at
go
time.
ahead with
So the additional pieces, and I just want to talk about conflict of interest free case management on the mental health side. One of the things that was put into place ended up creating a situation where adults with serious mental illness, again, that's a SAMHSA term, are moving from habilitated to rehabilitated. And so we're taking folks who have really high acuity, high needs, and they're flipping from habilitated to rehabilitated. What this means is that they can only be in these residential settings for a certain number of years, and then they have to move on from them. And for some folks that will work, but some of our highest acuity folks, especially our aging population who meets the criteria for a serious mental illness, would end up essentially or potentially being exited homelessness. And so we're asking for a work group to figure out for that small subset of the population who meets that criteria, to figure out what we are going to do with that small subset of the population. And that's going to be a working group with DMH Dale, similar partners.
good, thank you. That's good. So we'll see that.
We'll see that.
Okay, so now we got it.
Those are the two things.
Thank you. This is good. This is a good setup for tomorrow. We actually get a chance to make decisions. Okay. You think? Who knows? Listed is going crazy with all of the changes.
Oh, I can't.
But she's doing a good job.
We weren't sure.
No, not at all.
That's what I thought. Okay.
You're not late. Only your usual fun.
I just want to make sure
I have a brother just
Wow,
like
see.
that.
I'm just trying to line up next week because I have no idea how many bills are headed to me.
Well,
That's what I think.
so we have folks in here to remind us about S-154, the biomarker bill, which came to us from finance, and it would be good for us if we could at least get it back in some condition to finance. Because I'd have another week to look at it. And we have two folks here who can speak to 154 briefly. Can you do that? Great.
So.
It's up to you how you want to structure it.
Thank you, sir. It's human cost. Mike Rolo, American Cancer Society, Cancer Action Network. I did email testimony in and I asked to have it printed up, and apparently everything else printed up that, so I apologize, I'm gonna use my phone.
Well, that's fine.
But on behalf of ACSPN, I want to thank you for taking this up. So the timely access to guideline indicated comprehensive biomarker testing will enable more patients to access the most effective treatments for the disease and can potentially help achieve the triple aim of healthcare: better health outcomes, improved quality of life, and reduce costs. Progress in improving cancer outcomes increasingly involves the use of precision medicine, which uses information about a person's own genes or proteins to prevent, diagnose, and treat diseases like cancer. The biomarker testing analyzes tissue, blood, or other bio specimens to identify mutations that may impact treatment decisions. This testing is an important step in accessing precision medicine, which includes targeted therapies that can lead to improved survivorship, better quality of life, and better quality of life for cancer patients. Unfortunately, not all communities are benefiting from the latest advancements in biomarker testing. These include communities that have been traditionally marginalized, including communities of color, individuals with lower socioeconomic status, and people in rural communities, and those receiving their care from non-academic medical centers are all less likely to benefit from the benefits of biomarker testing. Trying to skip ahead, I know we're crushed for time, but I want to be clear. Biomarker testing is not indicated or appropriate for all cancer patients. We are not advocating here today for universal biomarker testing. Rather, this legislation before you was tied to rigorous sources of medical and scientific evidence, a guide who should receive this testing. When patients forego unnecessary care, there are direct and immediate results in the individual's out-of-pocket costs, system-wide costs, and often in terms of improved quality of life. Avoiding unnecessary side effects or ineffective treatment can also result in cost savings and can better support a patient's ability to work, support their family, and engage in their community. The power of access to biomarker testing is really a game changer for cancer patients. And S-154 would make it possible for all patients to get the right treatment at the right time. I want to thank you for your time this morning. I also wanted to draw your attention to one of the handouts I emailed you. If you need another copy, I do happen to have some in front of me. But it's about biomarker testing and cost savings. There are cost savings to the individual, and there are cost savings to the system and to the care. One study has indicated that for CVS Healthcare actually looked at total cost for care for non-small cell cancer patients who receive a broad panel biomarker testing compared to a narrow panel biomarker testing. The cost to the carrier was $1,200. However, they saved $8,500 per month per member that received the broad panel test. So that's significant savings. There's also savings indicated to Medicaid. There is a cost obviously associated with this. I know that will come up, and it's probably more concerned at the Finance Committee, but on the low end, we have 8 cents per member per month, and on the high end of Massachusetts, which I would say a much different system than the state per month, but it's 51 cents. But there are still potential costs associated with that. And I can actually email you the entire Milliman report. It's several hundred pages. I didn't print it out. All the trees thank me for that. But I'm happy to provide that. But I don't believe I've emailed that yet. But this is truly access to this testing is a game changer for patients. And there's one sitting behind me that wants to talk about her experience. I think unless there's questions, I'm happy to answer whatever you have, but I think you can hear real life experience.
Let's hear from her and then we can ask.
I'm not going
That Ledge Council coming in. This is great.
Yeah.
Appreciate you
Thank you.
coming in.
Of course, thank you.
Thank you for this opportunity. My name is Adrienne Frederick. I am here also on behalf of AdvaMed. We are the largest device manufacturers in the country. We represent about 650 members. We also have about 80 companies that specialize in diagnostic equipment. We are here in support of the bill. This bill, it's not only cancer that this bill impacts. It impacts arthritis, Alzheimer's. This is a huge spectrum, but the story I wanted to share is mine. I underwent biomarker testing when I was looking at a cancer diagnosis as a graduate student in Boston. The test at the time was $2,500 a test. I was a graduate student. I was fortunate that I was in Massachusetts. I had access to Romney Care at the time. It was not Obamacare. I think we all have that now. But my parents were willing to spend the $2,500 a test to let me have this test because we talked about it and it would make a huge difference in my treatment. I would have to, there was a potential that I would have to go through a series of invasive tests. I would have to go through a bone marrow test. I would have to go through any number of tests that would have to be continuously repeated throughout my life. Because while I have a blood disorder, this is a blood disorder that stays with me my entire life. And the other thing that compounds this is that the treatment varies, whether this has a genetic risk factor or if this just is a naturally occurring mutation. And those changes are a huge difference because if I was on that treatment of drugs, that could actually impact me negatively. And so these biomarker tests have allowed me not to undergo invasive care. I go to a hematologist once a year and we run a blood test. He and I joke a lot about World War II history because I love World War II history and he is a buff of that. And we talk about, okay, I'll see you again in a year. Maybe we'll run another test. those tests are now covered by my insurance because I have a private employer. But
Are they still $2,500?
no, they have gone down in price.
Okay,
They have gone down in price. They're no longer $2,500 because this was 2009. These tests were just coming out. They were just being marketed. I was actually being treated at an academic medical center. And now these tests are, at the time, I could be wrong about this, maybe Mike can, and the others can correct me, but my understanding at the time was these were mostly used for cancers. And now we've realized through precision medicine, through not having to put people through step therapy, through sort of a trial and error phase of if we can determine something right away, or we can determine it in a less invasive way, it saves the system costs. People are not taking time out of work to have ill side effects after a treatment that may not work. And this gives people a little bit of hope to say, I am getting the best care possible, because then you're not wondering like, well, what if this doesn't work? There's a little bit of hope that you're like, okay, I've undergone this test. This is what is indicated for my treatment. I understand it may not work, but I also then know I'm not looking at 6 months or a year of getting hooked and brought in and, oh, maybe we'll do a scope something. Let's just see what happens if we stick a needle in you. It was a little traumatic at the time, and not really understanding what's going on. And the other thing is that patients don't often understand that what these biomarker tests are. They just say, oh, we want to run a test and this will help. And so I think also Mike and others have been doing a lot of education about what these biomarker tests are, and allowing these people to have this option is a wonderful thing for people to continue. And I'm sorry, I would have prepared a testimony a little better, but I was here to speak on behalf of that.
it would be terrific if you could send some written testimony in for us and we'll have it.
Yeah, I have Adam's written. I will send. I meant to send it last night. Testimony on behalf of Adam. But
Thank you. And the cost of the test is important. Obviously, having it fully covered for eternity might be a little difficult, but having
the costs have gone down so much
Yeah.
because it's a volume thing. The more people that have access to it, the lower the cost comes.
of course,
And the more that
you know,
competition in the market also helps. That when you only have one company that's doing the test, we represent now 80 companies that develop these tests. So
Everybody that has information on cost, should get it to Charlotte Strasser in the finance committee. We're gonna be really pressed getting these things out next week, so the more we have in advance, the better.
right.
And the sooner you'll probably get the
Yeah. One last question.
Well, it's not a question. I have in my notes from previous testimonies that the average cost can now be between $46 and $400 in testing.
and that's the change in 15
Right.
years. 16.
Right. So it's not overwhelming.
But that also saves the system cost because then, like for me, I didn't have to go through chemotherapy. I didn't have to have a number of tests, and I was still contributing to the economy. So,
Or potentially surgery. I mean,
right, like it's a number of things.
No, when you have a biomarker test, the $2,500 or $46. Do they just go in and do one biomarker, or do they go in and do 100 biomarkers?
Just depends on the test. So what I just have,
So that's not the total cost, it's per
Per
biomarker.
it's per test. And so some of the tests are multi-test, they're a large panel.
Okay.
Mine were very specific because I have a very rare blood disorder. There's less than 100,000. I think it's less than 100,000 people that can say it's weird. The Dana-Farber studied it, so
It's good hospital.
Oh, good to be in a study.
yeah. I was not sick enough, so I did not qualify. But
Daughter worked there in a work study when she was in college. No. Testing anthrax, it made her mother.
Oh, wow. No kidding.
She said it's all in.
Oh, under the hood. Thank you. And we'll look forward to looking at the testimony, and we will go back to the bill tomorrow. Hopefully.
Madam Chair, so sorry, Jenny Morgan with the Alzheimer's Association. I know you guys were so gracious for the opportunity to speak before, but we actually have an advocate here as well that can speak to personal experience. I know time is so short, but
We are short.
Okay,
We will, if, what we'll do, if if you could stick around either here or in the hallway. And then as we go through our other bills, we may get back to this one.
okay,
We've
perfect.
got some real pressing issues.
Absolutely.
And I appreciate your coming in very much.
Thank you.
I appreciate it. And anything you have, you can also send.
Absolutely.
Super. Thank you. All right, so Jen is here and we're moving on with markup. Water bills. And I don't know about what you did last night. In addition to reading about what was going on in my district,
Yeah, you were.
I read through all the witness testimony for all the bills that we're looking at today. And I've made some comments. I don't know if you guys got it. Okay. I went through and identified my own decision points. See, that's I do. Sorry. Huh?
That was struck by.
What?
Should be done.
What?
It's free toothbrush day.
Oh,
Free toothbrush day, I know, but I said.
Free toothbrush day?
They
paying sales tax on that?
Wait, we get it through crossovers, then we can do
Stamp
samples.
first, not sales. Samples.
All right.
I've got to check.
Oh, transmitters,
I don't know either.
Madam Chair, which bill would you like to start with? So
190.
190.
You go there.
I'm
gonna read the list.
Sorry, Jessica.
I can do it.
I'm gonna come back because they're gonna come.
They're trained, okay, thank you. I appreciate it. Leave your bag there. Gonna leave money.
I'll just be in the hallway, Senator, if you need me for.
Why is that?
Oh,
You're having trouble accessing that page.
I've been getting that.
Why couldn't you get today's agenda?
No, I don't.
Okay. Trying to change it.
Do you mind closing the door?
Thank you. All right.
Okay, so we're still live. And
I'm sorry.
It's okay. Everybody needs to talk to everybody. So draft, the new draft that Lindsay just put up is draft number 2.1. Okay, good. We have it.
That's everything on that.
So we went through sections 1 through 3 yesterday.
That's 197.
Oh, that was 197. 190, we went through reference-based pricing.
Yes.
And we were having a conversation regarding, how to continue the implementation of RVP. And I think I'd like to start there if I could.
All right. Good morning, Jen Harvey, Office of Legislative Counsel. Actually, and Callista, if you have a chance, can you get me hard copies of all of them that I sent? I'm just the 3 I sent you. Thank you. And we can work anyway, but it'll be helpful for me and marking up. So I made changes based on your conversation yesterday. So this is just to orient us as 190, currently entitled an act relating to Green Care Board reference-based pricing and hospital outsourcing of clinical care. I changed it, you get it, see at the end. So section 1 is on reference-based pricing, but I actually took out the parts we were talking about because I moved them based on your conversation yesterday.
Okay.
So here's what I did. I kept the new section in Title 33 around targeting reductions to the qualified health plans, qualified health benefit plans. So that language is now not highlighted.
Wait, don't go too fast. What page are you on before you zip along?
Yep, so this is page 4. It's now section 2. I don't remember
Got
what
it.
it was.
Yeah.
And it is limitations on hospital reimbursements. So this is the 250% cap on registered carriers prices for hospital services for enrollees in the qualified health benefit plans, and the language that goes along with that, but I added the purpose to the purpose section. Hospitals shall not increase the amount they charge other commercial plans or private payers for various items unless the board authorizes the increase pursuant to a new section that we're going to look at next.
Wait till the new section.
Yep, and then I also added language saying in its review of premium rates in accordance with the rate review statute, the board shall ensure that the limitations on reimbursements established in this section are appropriately reflected in the premium rates for qualified health benefit plans. That was something that had come up yesterday about making sure that those limits flow through to the QHPs. So that's what that language says.
Correct.
Then I added a new section put it in with hospital budgets and budget review, what I now call hospital budgets and budget review, because it allows us to do some more stuff in this chapter. I added a new definition, the same definition of Medicare adjusted base rate, which I recognize is still under scrutiny discussion. But the concept being to have a definition that would go in this chapter or subchapter in Title 18, and then adding a new section on targeted commercial reimbursement reductions and directing a hospital to implement, and I may have terminology wrong, so I'm happy to be corrected by the board or the hospitals, but shall implement any commercial reimbursement rate reduction ordered by the board under a hospital budget order through the limitations on its commercial reimbursement rates for qualified health benefit plans in accordance with that section we just looked at that sets the 250% cap. To the extent that a hospital is required by the board's budget order to reduce its commercial reimbursement rates by amounts greater than the reductions achieved under the QHP rates. Thank you. The hospital shall reduce its commercial reimbursement rates that exceed 500% of the Medicare adjusted base rate, or if the hospital doesn't have any of those, then by reducing its commercial reimbursement rates that are the highest in relation to the Medicare adjusted base rate. This was based on a conversation yesterday saying, start with QHPs. So the language we looked at yesterday said, reduce anything over 500% of the Medicare rate and 250% cap for qualified health. This instead, based on the conversation yesterday, says first do the QHP, focus on the QHP limits, and then if the hospital still needs to further reduce its commercial reimbursement rates, then you look to the 500%, or they don't have any of those, the highest in relation to the base
I
rates.
have a question here. Obviously, there's more people have been contacting us, and so the question is the 250 that is here going to be implemented immediately on top of everything that has happened last year?
I mean, I think the timing in here is yes. But
Yes, yeah, Emily Brown, Green Mountain Care Board, my answer is yes.
So what does that mean in terms of hospitals? Period.
So we have our hospital budget guidance right now. It's a draft issue on our website, which calls for most hospitals to reduce their commercial reimbursement rate by -1%. So we are asking hospitals to cut. What this legislation does is requires that reduction to be satisfied through the QHP costs, right? The healthcare costs, underlying healthcare costs for the QHP plan. So that those savings are to individuals and small groups who are enrolled in the QHP plan.
So it's actually consistent with the budget guidance.
So I
So
think
it's how that budget guidance is achieved.
correct.
What we're putting in here.
Correct. And just to clarify too, it doesn't mean that every hospital by implementing this legislation, every hospital will be exactly at -1%. But if for instance, a hospital implements the 250% of QHP, and let's say it ends up based on their the population of QHP patients they have at the hospital, it could end up being slightly more than the -1%. It can also end up being slightly less than the 1%. And I think that's why here we have that language about applying then any further reductions are needed to those high dollar services. Okay. High cost services.
And then I just want to also note, so the piece we didn't get to yet is the kind of hardship language. So if a hospital demonstrates to the board that the limitations on hospitals' reimbursement rates for QHPs in 33, in Title 33, or this section, are having a negative impact on, and I use the same triggers as in the Act 55 outpatient prescription drug. I don't know if those are the right ones. So just noting that that is literally where these came from, but there may be different criteria that people want to suggest or that the committee is interested in. But if a hospital demonstrates the limitations are having a negative impact on access to care, quality of care, or the sustainability of rural healthcare services, or a combination, the hospital may propose to increase commercial reimbursement rates for one or more of its service lines, such as primary care, and the board would consider both the demonstrated impact and proposed increase to reimbursement rates.
Okay. We'll have to get a comment from.
Right, people are all just seeing this language now,
Right.
so,
Understood. And we worked on this yesterday, so.
right, so we talked about this yesterday, I drafted it yesterday evening, and people are seeing it the first time.
I'm glad somebody else worked on it.
All right, then the hospital outsourcing. So when the last draft we looked at struck through a bunch of language and put in the budget guidance and the reporting. So that is, it's just, I've changed the section number, but otherwise the text is unchanged. Same thing for excluding reference-based pricing from the scope of healthcare professional bargaining. I changed the section number, but otherwise just incorporated that piece that we looked at that was remaining after everything else was struck through. Just the change of the section number on appeals agreement care board orders. After direction from the chair, it's proposed striking the hospital audit section that allows the chair of agreement care board to conduct investigations and examinations, including audits. So now we have no section change and incorporated the changes on the health system performance tool that were proposed in the last draft. And implementation, contingency, and then we have the study committee. So I incorporated everything in the last draft in here with a few changes that are highlighted. So the first is it's pretty ambitious timeline in the language you looked at yesterday. It had this group providing its report on all of these topics by December 15th. So after consulting with the chair, we have a new proposed date of February 15th, so an additional 2 months, and moving out the expiration date of the study committee by 2 months as well. And then again, after consulting with the chair, this would take out language around per diems and instead specify that members would not receive per diem compensation and reimbursement for participating, which is the language we used in some of the groups last year in Act 68. And it would appropriate $200,000 from the general fund to the treasurer's office in fiscal year 2027. And that would be specifically to pay for the services of consultants or firms who are authorized to work with the committee, facilitate meetings, write the report. And then I had proposed in after section 10, which still has the act taking effect on passage, that the title would be an act relating to the agreement care board, reference-based pricing, and studying the creation of a public employee health benefit reporting. Since there's significantly less on outsourcing, so it didn't seem right.
So the language relating to, go back, the language identifying VHI and VSEA for inclusion and RBP is, we don't have that. We have the study.
Right, you have the study.
Well, I'm open to conversation at the table. I think it might be helpful if folks know that we're actually looking at reducing some of the costs associated with especially school-based healthcare services. So just having it in there for future consideration in some way. But based on the analysis that's come back, I don't know. We don't know that this study is going to go through. It has to go down the hall. We have to find money. So that's where my thinking is, if we leave out the VHI and the VSEA and the initial part of the bill, nowhere. That whole study could be dropped down the hall, so. So you can see, I would encourage some mention of it in the future. A future consideration by the board. I'm looking at the board.
We'd be happy to, I mean, we are planning, we did the study, right?
I really did, it saved a lot of money,
Correct.
but it also, if we put it on top of everything that's going on right now, we might kill the hospital, so we don't
Yeah.
want to do that.
Right.
Whole point, so so putting it in the future makes some sense for me.
Yes, and if you want to put something in, I just need to understand what you're wanting to put in for the future.
So right now, we're looking at QHPs. That would go back up into section 1, it's at the top. Targeted commercial reimbursement rates. We could add just a sentence that would have the board review its analysis and look at how to include reference-based pricing for those cohorts, ensuring that our hospitals are not negatively affected, just something like that.
So would this be just a standalone session law provision directing them
It
to
would have
look
to
at
be,
things?
yeah.
Doesn't seem like if it goes in that statute that kind of talks about,
I mean, all I hear about when I go home is, how come our property taxes are so high? It's all because of the full healthcare costs. And whether that's true or false, it's something to be considered. It's a big concern.
and so it would be directing, I mean, do you want them to report back to you or just to be considering how?
To do it, either do it or don't do it. I mean, put it into the process for consideration as reference-based pricing or as pricing goes forward with us. I don't know how else to say it.
Yeah, that's fine. I just also, so we don't regulate VHI or the VSEA, so I think it would be important to make sure,
Yeah.
like, I'm thinking about what this analysis would entail. And I imagine it would be, you want more of an in-depth look at, right, implications of reference-based pricing. I know we did a study which was not, it's my understanding, was not based on using VHI's claims directly, but.
Right, you would need to update the study, I think.
Correct, yeah.
Commensurate with the methodology that we're implementing for the whole state.
Right. And so I just want to flag that I think it would benefit the Green Mountain Care Board if we could in some way, if it was implied in this language, that we would be able to work either with DFR or VHI
Or both.
or both, right, on getting information to make sure that it's not ambiguous, that we actually would have authority to do that. I think that would be important since they are a private self-insured entity.
I think that would be appropriate.
Okay.
We can't do it without their support.
And same, and you also mentioned the state employee plan. I think it would be the same. Yeah, I would like there to be just a specific authority for the Green Mountain Care Board to access data related to those plans.
Cool. And that's going out. That's not now.
Right.
You can't do it that fast.
Correct.
Right, but it sounds like you're wanting them to kind of update with real, with
Yes.
more actual claims experience data, the analysis of the impacts of reference-based pricing on if it was targeted to those plans,
Right.
the state employees and teachers plans. And then report back on
I'd like them to how to implement, how to do it. I think if they can report back, but also how to act. Yeah.
Just to
Senator
put
Benson.
some clarification in your study, I assume you're also looking at how that would impact certainly our rural hospitals.
Correct, exactly.
Oh, yes. You need to have that in there.
Yeah.
That negatively
Right.
impacting.
Yeah,
How did we come up with the 500 and the 250?
the board and the hospitals.
Sorry, I missed the question. Was there?
Come up with 250 and 500.
Oh, 250 came from Oregon, came from the other states. It's equivalent, using our methodology, it's equivalent to what other states have done.
Okay. I'm still concerned about the critical care hospitals and will that, right?
But we built an off ramp into the current.
Yeah, I mean, it's basically, they're gonna go under the.
We don't let them go under.
No, right,
That's the whole-
prevent care board would be able to now,
Just.
right, adjust upwards.
Yes.
If they have to. Right.
Who has their hand raised? Oh,
No, you can't see it.
Oops.
Senator, I just, Senator
Oh.
has her hand up.
Senator Bueller,
Oh, because she doesn't have her video.
are you there?
I am here. I just wanted, I'm sorry, I'm not getting better as quickly as I had hoped.
Well, then you just stay home.
Yeah,
Happy to have you on Zoom and to get better.
I just wanted to chime in that I guess I'm disappointed that we're not able to act. I understand that we need to protect the hospitals, but Senator Lyons, to your point, all I hear in my district is about the cost of healthcare, and I just want to make sure that this study is as specific and as strong as possible, and that maybe we add intent language that really makes it explicit what our plan is and what our hope is to come out of this. I don't know if anyone agrees with me, but I'm feeling a little disappointed right now that we're not able to take bolder action at this time.
So, yeah, I'm in agreement with you that we need to act. It's not something that can happen right away for a couple of reasons. One, the board needs to identify, do the work, do the analytic work. And looking at the board, they're going to comment. And then the other part of this is right now, the hospitals are already under a budget order, and to pile something else on top right now might be the straw that breaks the camel's back, and that's what we're trying to prevent. Go ahead, Emily Brown.
Emily Brown, Greenbelt Care Board. So I would also, I hear the frustration. I think there are other aspects too of the VHI plan that is also important to point out, like the benefit design, which again, the QHP benefit design is largely set at the federal and state level. So it's predictable. We have control over it. There's other aspects of the VHI plan that I think it would be important to look at. If you're going to look at the underlying costs, it's not only the underlying costs, there's other aspects of the plan that I think if you wanted to take that kind of, if you're wanting to tackle the price of healthcare for teachers, it's not only about the underlying costs, it's about looking at the structure itself. You could look at several aspects of the plan design. You could look at, I know there was a study done, I think it was in 2018, there was a committee style group, but I think it's important to not just, okay, thank you.
Yeah, no, we get it. We understand.
Thank you.
Okay, quick comments, because we're gonna move along. I'll let VHI talk, and then, I think the hospitals had to hand up first. Want to go first or second?
VHI.
All right, go ahead.
To be clear, Colin Robinson, Vermont NEA, speak on behalf of Vermont NEA, not VHI. Couple quick points. Definitely appreciate the acknowledgement of the issue that has been shared. Obviously, yesterday we spoke to the value and importance of doing this with urgency. And also understand, look forward to seeing the draft language that Legislative Council comes up with. I do want to clarify a couple points. One is this committee's received testimony from VHI about the fact that the two biggest cost drivers in VHI costs are the same as all others. So, I think plan design is not the fundamental cost driver of it.
So we're not going to get into that debate.
Yeah.
And I understand your concern here because you're not getting into the plan.
And
The benefits, and some of the benefits, are there.
understood. I just wanted to correct the record and also just,
Understood.
Lehigh is going through the process of plan redesign right now.
Oh, good. Oh, so that's good to know. All right. So that's good to know for everyone in the room. Yes. Devin.
Devin Green from Buzz. I going to the 250% for the exchange plans. I appreciate the Green Mountain Care Board's efforts to strike a balance between moving quickly and not closing any hospitals. So thank you for that. I support the work of going for those high prices for all Vermonters first and having it more across the lines. I know Blue Cross Blue Shield and hospitals are starting work now. We had them at our board meeting. They are sending out negotiation letters. Having this 250% piece sort of undermines that ability to try to work that out with Blue Cross Blue Shield to bring down those high prices. So we do have a concern there. And then we also have a concern on the definition of the Medicare base rates, especially if hospitals are going to be doing these calculations. We think it should be what is paid to hospitals, which is what we know. And that's what other states base theirs off of, as presented by Valiant Health. So we want to be compared fairly to other states. We want to know, we know what we're paid. And then at the same time, there are a lot of policy determinations that go into that amount that hospitals are paid. You look at the rurality of the hospital, you look at what type of hospital, you look at the patient mix. And so the federal government has made a determination that these policy considerations are important. And so we think that that should be the base as opposed to something else that's not necessarily what the hospital is actually getting paid by Medicare.
Are we talking about loaded rates?
Yes.
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 So that's something that is the board, should we be mentioning loaded rates in here?
No.
Because there should be a comparative analysis with similar hospital types.
We can certainly do the analysis, and that's part of the work that we've started and anticipate continuing. We explored the fully loaded amount and with all those policy considerations. It includes, performance on quality. It includes, academic teaching. It includes technology. It includes all of these Medicare investments that may not translate directly to this program. So I think what we were really going for was apples to apples, and then discrete adjustments that we can identify.
It doesn't say that here. It doesn't say that in the bill. And you're asking us to put some very discrete information in the bill. You're not asking us to put in it says Medicare adjusted base rate. So is there any reason why we can't reference, at least, are you going to be writing rules
Yes.
regarding this? So is it possible that we could reference the information that you have just shared with us in the rulemaking process so that offers reassurance that consideration will be given to different hospital types?
Yes.
And based on what other states are doing? Because if it's just carte blanche, there's a lot of trust in this room. I just want to say, from my perspective, there's a huge amount of trust. But when you don't have something in statute and you go ahead a few years, interpretations can be made. So if there's a way that we could put that in, that would be helpful. And so I'm thinking about something around rulemaking, around Medicare adjusted base rates or loaded rates, or including the criteria that you had just indicated.
Yeah, I think it's alluded to in the existing Act 48 language, Act 68 language, sorry.
We can reference Act 48?
68, yes.
Or 68.
right, and must consider different roles of hospitals and community needs.
Yes, we
And that's
did put that.
exactly what we are going to do in the rulemaking process. So this is the starting point. It is not the ending point of the policy.
Okay, well then it's important. I
show
think
you let's put up the
Yeah.
existing language. So where I'm in 18 VSA 9376. And it says, in establishing reference-based prices for a hospital, under this subsection, the board shall consider the composition of the community served, including health of the population, demographic characteristics, acuity, payer mix, labor costs, social risk factors, and other factors that may affect the cost of providing care in the hospital service area, as well as the hospital's role in Vermont's healthcare system. Is that what you're talking about?
Absolutely. So that's the work we have ahead of us over the next, year.
Already where I put the language
Which is how do we do that in a way that makes sense for Vermont, right? Like, we don't want to assume the Medicare policy, especially right now when that could be changing. We want to have flexibility to adapt our program as the environment evolves and make sure it makes sense for our hospitals.
What section of law is that to be read?
It's in the, what is it in here? Well, it's not in the
33, I don't see 18.
It's not in the, so section 1 of the bill is amending 18 VSA 9376E. That is, and in 9376E is subdivision 2B, which we're not amending, so it doesn't show in the bill, but it does exist. So the bill picks up right here at 3A, and in existing law, it's here in 2B.
Got it. Do we need to say anything about any of the more contemporary work that's going on with hospitals, hospital rate setting, loaded rates? Should we say that?
I think we
Comparison
should
with other
compare.
states?
I think we definitely want a way to compare to other states, and I think that will be important. So we're happy to, and as I mentioned, that's already included in our analysis. I think other states are actually looking and excited for this new definition. But I think it's very important to do that analysis.
Okay, maybe just stick something in there.
Devin from us, so are we? So we're sticking with that, because the other thing that has been thrown in here is that the hospitals are reporting out their prices as a percentage of Medicare, and we can't do this base rate calculation. We know what we get paid, but we don't know how to convert to the base rate. So I feel uncomfortable having this in statute without further discussion with the Medicare board and clarifying.
Don't you feel comfortable having that?
So let me put up the language where I think Devin is talking about, so
Okay,
that would be evaluating whether there should be some additional clarification there. This section would no longer have a definition of Medicare adjusted base rates in it, because it's going in different pieces, but I think you're talking about when making public the charges.
Yeah,
Each hospital shall include in its machine readable files pricing information shown as a percentage of Medicare rates, as well as in dollars and cents. And so I think the question that you're hearing is that intended to be Medicare adjusted base rates, in which case the hospitals don't know how to calculate that, or is that intended to be the Medicare rates that the hospitals receive, in which case they do know what that is, but it won't be the same as what's happening in other places.
right. And the same for section 1C about our provider contracts entered into and begin expressing it as the Medicare. Yeah. The other piece of this is the PPS or the critical access hospitals cannot do the PPS, the conversion
They're
to,
not PPS hospitals,
they're not PPS.
but I can't do it.
We don't know how to convert
Right,
what we're paid to the PPS
right, got it.
prices.
They're critical access hospitals. So the question, I think.
I mean, I think we need to get there.
Yeah, we're in a strange place right now.
Yeah.
Is it something about putting a goal in here? I don't know. I can't answer this question. This is not a question that we can answer. We're listening to what you two are saying.
Right, I think the issue is if you don't specify which
Mhm.
which Medicare rate you're talking about for these provisions starting October 1st, 2026, and hospitals showing
Mhm.
the information that they're required under federal law,
It's all over the place.
which, right, you're hearing from the hospitals that
Okay.
there's one way in which they can provide that information. That is not necessarily the way the board is wanting that information to be
Understood.
presented. And if you don't decide which way it goes, you may not be happy with the results.
Well, I'm leaning toward the board right now for this one. I think, we need to have something that they can work with and very sympathetic to the hospitals on this. I think we put language in that will help going forward on what to say at this point, so let's leave it for now. So what are the hospitals asking for? What will the hospitals report?
Again, I think what you're hearing is the hospitals who report the information that they know, which is not the Medicare adjusted base rate, but they're what you were calling, Madam Chair, the fully loaded
Right.
Medicare rate.
Mm.
That's different from the limitations on hospital reimbursement language. Yeah.
And they report the fully loaded rate until we establish the rule, in which case, and that gives us more time.
Would that work?
Yeah.
Thank you. That would be great. Let's do it. Thank you. I was hoping something. Oh, wow. Alka-Seltzer. Thank you. Good work.
Come up with that more official way of saying fully loaded.
Sounds like
What hospital
This
they're
is
reimbursing.
really important.
The chili
This
cheese
is so
version.
important.
Yeah.
Okay. We've been working on this thing since January. Okay. All right.
Devin, again, there's also the critical access to PPS conversion. piece
That would
that's
be
still
in
in there.
rules.
I think, again, for now, I think that's fine. I think part of the analysis that we'll do feedback that out. But I think it would be good to have the language such that when the rule's in place and we all have a clear methodology, that reporting will align with that.
Cool.
So we'll put something in saying that for C and E, the hospitals will use the amounts they receive from Medicare as the, in calculating the percentage of Medicare until the board has, I guess we'll talk a little bit around if it needs to be that applicability date or the effective date or
Yep.
something earlier than that. But, okay. Great. What else do you want to discuss?
I don't want to talk about anything more. I think we've been through the bill. Other
We have been
questions?
through
Huh?
We have been through.
We've been through the whole bill committee. Do you have specific questions about sections of the bill at this time?
No, I think it addressed my concerns, which was an off ramp of the 250.
Yeah.
Which we have in here. And I was also concerned about the E audit, which has been taken out. So
I feel a lot better about it, yes.
Yeah, I knew that was a concern that was in the committee and I tend to take it out. And I think I understand that there are those who would like it back in. But I think at this point, this is not something we discuss, but I'll pick it up a bit.
Okay, so I think for tomorrow, we'll be back with some randy new provisions. So incorporating everything that's been done so far and with some new provisions around the Medicare rates to use in the provider contracting and public reporting and around creating a new section directing the board in collaboration with DFR, BHI, and DHR to analyze and report back on reference-based pricing for implementation of reference-based pricing for school employees and state employees and the impact, projected impact on hospitals require the board to get access to data. You need data on claims experience. Is that what you need to be able to do the updated reference-based pricing for school employees and state employees?
Yeah, you need all their claims, yeah.
To claims, I would say claims data, and then have the board report back on implementation, timing, whatever else you want. Is that
Yes,
what you're thinking?
that sounds good. Thank you. And then we'll, when we look at it tomorrow, I understand that there might be everybody wanting to comment. We're gonna sit here at the table and we're gonna decide vote or not vote. Tomorrow is it for us. We'll look at it. Okay. I have a question. Next bill.
Yes, which bill?
I thought we'd do 197 for the continuity, and then we want to go to 64. And then, 189 is there, but we've finished that pretty much.
You should know, I mean,
We should
still look at it.
Okay, I'd like to
Have a new draft,
Okay,
but
so-
we can do,
take a quick look at that.
do 197.
The 197.
So for,
I can't tell you how much fun I had last night reading all this information, all these bills. It is really great to do that.
so 197,
2.1.
There we go.
2.1.
2.1.
Working out today.
So we went through the sections 1 through 3. Now I'm caught.
We went through the
Yeah.
sections 1 through 3, and I think I made a couple of very minor changes on which that should be, but, having editors look at it. Yeah, so I made a couple of just technical cleanup changes, having learned from different folks, that the NCQA score is now just the NCQA patient-centered medical home score and doesn't include the language about physician practice connections. So I took that out in 2 places. And the language around the amounts from health insurers, beginning in 2027 being in amounts at least equal to Medicaid, and the editors suggested maybe that they Medicaid payments, which I don't think that. So I added that language. And then this is a piece that VMS has proposed that I think is still up in the air with AHS. They have not weighed in on yet. So this is in making recommendations, further recommendations on modifications to payment amounts that the director of the blueprint would not only strive to achieve or maintain parity across payers and payment methodologies, but also to adjust payment methodologies annually as needed to adequately support practices in maintaining CQA PCMH status, that's the updated term, or meeting other requirements for participation in blueprint programs.
Can I ask Nolan a question? Will this have any negative effect on our Medicaid process at all?
I don't know the answer. For the record, Nolan, I won't have disclose. It will if this results in increased participation of Medicaid.
Right.
But if it's Medicaid, we're flat and insurers were going up, it wouldn't impact state's budget. It would have impacts elsewhere. But that's the piece I'm not clear on is this requiring Medicaid to increase their PMPM or their payments? And I don't know. I'm not clear on.
Okay. And I just, so folks know, I did reach out to AHS and ask for how much would we have to put in our budget to increase reimbursement rates for primary care? Because I don't know the answer to that. And then as this shifts down the hallway, if we know how much, I got one number back with exceedingly low. And I said, well, we can raise it by 20%. No. So we'll wait for some accurate numbers, and we'll either do it in here or maybe it'll get carried down the way. And just a comment. Jessica, did you want to comment?
Jessica Bonner with the Medical Society. I just wanted to comment briefly about the potential impact on Medicaid budgets, that we were trying to be very careful to propose language that just says this is in recommendations. that, and to strive to maintain parity or make adjustments so that it's nothing requiring, if there are budgetary impacts, there's nothing requiring those. These would just be stated in recommendations that the legislature would then consider.
Okay. Thank you. That was good. That was helpful.
Okay, so those are the only changes I made in those sections that replaced sections 1 through 3. I did not give you existing sections 1 through 3 struck through. I just put these in instead of 1 through 3. And then because this is now 1 through 5, everything else gets renumbered.
Okay. Total number of sections is now 5.
Of the 1 to 3. And then there's the rest of the
So
bill.
1 through 3 is
traces
until
to
1 through 5.
Yeah, 1 to 3 becomes 1 through 5, but we're gonna take out a section. I think we almost catch up.
Okay.
Section numbers.
Let's go right to 6.
So 6 is the clinician landscape and site neutral reimbursement reports. I didn't make any changes in the content, just section numbers. Yeah, okay.
Did we? There was a mention about having the primary care advisory committee included in some of the work that's coming up here.
I think that was maybe in the context of
It's in the
creating a
transition.
separate committee.
It's in section 7.
So if they're already included in section 7.
Yeah.
But what I added in section 7 was that the agency shall incorporate the recommendation. So the section 7 has AHS in consultation with various groups reporting to this committee and has healthcare with recommendations on ways to accelerate appropriate transition of patients from hospital care to care delivered in a community setting. It talks about the recommendations, including opportunities to use community health teams through the blueprint. And then I added the agency shall incorporate the recommendations into the healthcare delivery strategic plan as appropriate.
But that's good. The more we can do things.
Yeah, right, that's what had been discussed yesterday. I struck the section relating to BPQHC.
Yeah.
Or committee discussion yesterday. Just changed section 8, the treasurer's office exploring regional universal primary care. I just changed the section number. Section 9 is removing the sunset on the medical student incentive scholarship program for primary care. And as we briefly discussed yesterday, there is money remaining in from prior appropriations. And this language is also, it's been proposed for the budget. I don't know if it's actually going in the budget, but wouldn't cost any new money unless there was an additional new appropriation, but it would allow this to extend into future years based on the money that's available. Section 10 is based on the request from committee yesterday around, Sharon had mentioned about notice when a drug is going to not be covered by insurance anymore. So I amended an existing provision of the health insurance statutes that require health insurers to notify individuals on a periodic basis, but at least once per calendar year, of any changes in pharmaceutical coverage and provide access to the preferred drug list. I added a new provision saying not less than, and I put 60, but you can pick whatever you
60
want.
good. We'll start
60
with
days prior to removing a prescription drug from its formulary or from the formulary maintained by a pharmacy benefit manager on its behalf. A health insurer shall notify all individuals covered under its health insurance plan who filled a prescription for that prescription drug within the previous 12-month period. The coverage for the drug will be discontinued and of the date on which the coverage will end.
Seems like transparency. That's really.
I can just turn around and ask Emily with her old hat on. Wrong.
That sounds great.
Okay, thank you.
Thank you for that.
And then I proposed changing the name. It still doesn't quite cover everything, but it has been enacted relating to establishing a primary care payment reform program, and that is no longer what the bill does. So I just did an act relating to payment reform for primary care, which doesn't reflect everything, but is still most of what's in the bill.
Okay.
Well, that's it. Where we are at that.
So why don't we do this, with this one? It seems like unless there are some burning additions that or subtractions that need to be made, I think we've been through the bill. What we'll do is, I'm happy to hold the vote off until tomorrow, but let's just put it aside for now. And if we want to come back to it later today, we can do that. If not, we'll look at it tomorrow.
Which one is next? You want to do 64 next?
How much does 189? I think 64 might take more, but
Yes, I think 64 will take.
so that's why I'm thinking spend most of our time on 64, go to 189.
189.
Everyone is here.
Get it done. All right.
You're welcome. That's fine.
Ready? Yeah, 3.1.
Yes.
All right, 189, 3.1. So again, this is an act relating to approval process, although this name changes as well for reducing or eliminating hospital services. So this modifies the scope we talked about a little bit yesterday. We talked about kind of the intentionality. So this would now say a hospital that proposes to intentionally reduce or eliminate any service. I had said intents and then looking at it, I appreciate. Yes, but to be fair, this is a legal standard of intentional, you know.
Yeah.
Hospital that proposes to intentionally reduce or eliminate any service, and then it goes into the notice process. So after a conversation yesterday about sort of wanting to have this process start before the statewide healthcare delivery strategic plan is established, I went back to just having it start. The Agency of Human Services shall analyze each proposed service reduction or elimination for consistency with the strategic plans. That's why it's highlighted but not bold. Put it back in. Consistency with the statewide healthcare delivery strategic plan once established and the community health needs assessment. Consider the community's response and the impact on access, and then provide non-binding recommendations on the proposed reduction or elimination to the hospital board and the public. Then it requires, if a hospital decides to go ahead, that they within 5 business days notify the Agency of Human Services to inform the agency's transformation efforts and future versions of the strategic plan, and the board to enable the board to review the impact on the hospital's budget. And then it strikes the process added in Act 68 last year, and instead has language directing the board, once it's been notified that a hospital can reduce or eliminate, after completing the process, review the impact on the hospital's approved budget, and allowing the board to adjust the budget as necessary to reflect the elimination or reduction, and which may include targeted reduction of savings. And then keeping the language requiring the board and DFR to monitor implementation of any authorized reduction or elimination would take effect on passage, and then it would become an act relating to establishing a process for reducing or eliminating hospital services. Not any approval.
Questions?
So hopefully that was what you were looking for based on yesterday's conversation.
Go ahead.
I just have Emily Brown, Fremont here. I have a clarifying question. With the budget review, is it implied that that would happen during the annual budget review process, or would this be a separate budget review process? Outside of the, outside of our budget
I think the
review?
timing may depend. I think if the notification happens in November, then it may not make sense to wait until the following September.
There's discretion.
I think there's discretion.
Great. Okay.
Because you're reviewing the impact on the budget.
Okay.
So I think, depending on that's how I read it, just not specific.
In a year.
Right, it may depend where you are in the year. It may depend on the significance of the impact on the budget.
Okay, that's helpful. Thank you.
So it does offer flexibility.
Right. I mean, it says upon receipt of notification, the board would review. So, but what the board chooses to do as a result, it allows the board to adjust a hospital's budget, which I think suggests you have the authority mid-year in addition to whatever authority you have at budget setting.
Go ahead, Deb.
Ben Green from Bob's. I just had a question about the return,
Okay.
it was on the last part where it says the payers and Vermonter. Savings related to.
Yeah, this language has been in for a while, I think, but it's not changed, but.
It has been in there. I was just thinking like, I really wanted to go to Vermonters, but I guess maybe it's up to the discretion.
Right, I mean, I think some of the return to payers
Payers
is to put it, is to
pass
be
through.
reflected in premiums, yeah.
Can we say something like, to be reflected in premiums, or is that too detailed?
I can't hear you.
Can we say something like to be reflected in premiums, or is that? too
That's what I was thinking, yeah. Yeah.
Sure.
Yeah.
Is that, I think that has been,
I think that works,
Yeah.
yep, I think that.
Yeah, otherwise it can go anywhere.
Correct,
Wow.
exactly.
right, well,
Well,
I,
I'm here, we don't.
I think the assumption was that would be tracked and reviewed as part of,
Yeah,
premiums, but,
It's reflected.
yeah, I'm struggling with.
reflected in premiums.
Right.
I'm not struggling with that part, struggling with how to get the Vermonters in there.
Vermonters premiums.
Well, didn't know if it was Vermonters outside of the
Oh.
premium amount, that's why I
Yeah,
wanted
that's
to
right.
do. So maybe I'll just flip it.
Well, do that individuals.
Um,
Pardon me?
These Vermonters that are affected.
It may depend, I mean, it could be, so, but I'll just flip them, and so it'll say a return to Vermonters. And to payers for, payers to be reflected in premiums. So I guess we'll say Vermonters to address affordability concerns. Payers to be reflected in premiums for. All right. I think maybe that works. Okay. Great. Let everybody, that one for you?
That one, when that one's complete, I mean, even before it's complete, maybe at the end of this morning, we might think about voting on that one, because we've been thinking. Full day to.
Okay, well, if you have a lot of conversation on something else, I may try to.
Yeah.
Update the document so you.
So now so I'm gonna take a 5-minute break. I know that we need it, and I'm 4-minute break. At quarter of, we're starting on S64, period.